Hello, everybody. Welcome to Tuesday VMR, afternoon VMR. It's my great pleasure to be here to discuss again with my excellent friend Kirtan, who's kindly signed on to co-discuss with me today, and all of our fabulous Academy members here that are helping to scribe and help us with teaching points. We cannot do this without you, so all of you are extremely important in this endeavor. And before we get underway, I want to introduce a first-time case presenter, Sneha, and also want to mention to everybody that's out there, by all means, do reach out. And if you have a case and you like to present, you can reach out to our case review committee. The email, I guess, if we have anybody has an email, see may put it in the chat, and we can actually help you put your case together. And that way you can feature on CPS and present. And it also can be helpful if you're maybe applying for residency next year. You can put it on your CV as a presentation. So by all means, please do that. If you don't have a case, we have some cases as well that we'll put together and share with people. So I just want to spread that message out there. But before we get underway, I'll have Sneha unmute and then Keaton unmute after that, and then everybody else.
Hello everyone, I'm Sneha and I'm junior consultant internal medicine from Chennai, India. And I work with outpatients and inpatients during my day. And we basically belong to a community hospital. We have a good team here. And I've been a big fan of CP Solvers last few months at least. And I wish I had known before, but yeah. So I'm very excited for the first case that I'm going to present and hopefully have more cases.
Awesome. Sneha, what do you like to do in your free time out there? What's good to do in Chennai?
There are a lot of things we can do in Chennai, but free time's a little scarce. So I like my quiet time and cup of coffee with some plants around. Yeah, some book novel if I can manage.
Awesome. Thank you. Next up, my our dear friend, Keaton.
Hi. Perfect. Thank you so much, Dr. Singh. Yes, Neha, we are so excited that you are with us. And I heard from our case review committee that your case is really exciting and really enlightening. So I'm like, I was buckling up that, okay, let's see what kind of case is this going to be. But yeah, please, thank you so much for making the time and coming to present the case to us. And always a pleasure with Dr. Singh. Now, in fact, I was just thinking earlier today that the most I have discussed with anyone in CP Solvers is actually Dr. Singh because like I have discussed with him when I was a med student and when I was a resident and even now as an attending. I think I discuss maximum with him on Tuesday because that's how the slots open up. So always a fun with him. And then as Dr. Singh said, we cannot do this without the help of our dear team members who are scribing and teaching. So Simi is helping with the scribing and Eugene is helping with the teaching points. So Simi, how are things going with you today?
Hi, I'm good, and I'm very excited for Sneha's case. I have seen her joining so often, and finally having her present makes me very happy. So, very excited for the case and discussion.
How are things with you, Eugene? All set for teaching?
Hello, everybody. My name is Eugene, and I'm from Ghana. I'll be doing the teaching points.
Thank you. And before we ask Neha to start with the case presentation, I also wanted to thank our dear team member Vijay, who is not here, but as Neha told us before that Vijay helped in putting together the case and like the format and everything. So thank you so much, Vijay, for helping with that. And yes, Neha, whenever you are ready, we can get started with the first telecon.
Okay. So I'll start the case. So this is an 18-year-old boy who presented with difficulty walking for the last 1 week. So he had been normal, quite normal, 10 days back. Then he developed some pain in the calf, which lasted for 2 days and had settled. Subsequently, he had some numbness in the right toe and then subsequently difficulty walking. So I'll stop here.
Keaton, you want to take first stab at it?
Sure, I can go for it. Perfect. Thank you so much, Sneha, for giving us the first piece of data. So looks like we are dealing with a young boy who is presenting with acute onset of symptoms. And the symptoms seems to be that there's difficulty in ambulating, right? So as always in medicine, right, that whenever you're dealing with a problem, it's very essential to characterize the problem in a good way so that we don't go down the wrong rabbit hole. So for example, if you ask yourself that what it takes to ambulate. So first, let's say if you are sitting, you need to stand up, right? So you need certain muscular groups to help you support your posture, right? Then once you stand up, you need to make sure that all your articular structures, so the joints which are necessary to bear the weight when you stand up, which includes like your hip joint, your knee joints, those have to be intact. And when I use the word joints, we also mean the surrounding articular structures. So all the muscles, all the tendons and ligaments, which are essential for extension and flexion, they need to be working in appropriate manner to bear the weight and then start walking, right? Sometimes what happens that maybe all those structures are fine locally, but their innervation is defective. So that's when the neurology comes into the picture and the whole neurological axis, starting from cerebral cortex all the way to corticospinal tract, to the brainstem, to the spinal cord, to the anterior horn cells, through the nerve roots, through the peripheral motor neurons, neuromuscular junction, and then finally the muscle, right? So this is the axis that we navigate. And then finally, let's say all of this is intact. Is it possible that still someone has difficulty in ambulating? It is possible, and there are two domains too. That whenever you start walking, your body needs the signals from the outside to help you walk, right? So called like the proprioceptive or vibration signal from the periphery, and the visual cues from your eyes, and the equilibrium signals from your ears. So if any of those is defective, so for example, we often know that how we use the term sensory ataxia, that sometimes people have severe deafferentation of their peripheral nerves, their dorsal column is affected in some way. And because of that, even though the whole neurological axis is intact as such, they still cannot walk because there is no peripheral efferents which can guide your body that what is the navigation in your external space and time, right? Similarly, if everything is fine, even the afferent nervous system is doing okay, but maybe you have something wrong with your vestibulocochlear apparatus, or maybe something wrong with your brainstem where all the signals are integrated, and that is why you are in disequilibrium state, and maybe that's why you cannot ambulate, right? So this is the advanced neurological function through which your ambulation can be difficult. And similarly, if you think about all the way in the cortex, we use the word known as apraxia. Apraxia basically means that you know how a function is supposed to be performed, like how a motor task is supposed to be performed, but you still cannot execute it because of the higher order dysfunction, right? And then finally, if we think about the last axis, like I mean, the last domain in this analysis is the pain, right? That sometimes everything is fine. Your brain is integrating signals fine, your osteoarticular structures are okay, your innervation is okay, but maybe there is just so much pain and discomfort. Maybe that's why you are not able to ambulate. So I laid down this broad framework to kind of emphasize that how important it is to characterize the problem well. Because if you take a wrong problem and try to solve it, if you imagine that, oh, this person has neuropathy, let me just try to solve the peripheral neuropathy, and you will solve everything, but you will forget that maybe it was not a neuropathy problem to begin with, maybe it was a apraxia problem, right? So that's why it is important to characterize. So in this, like in the next aliquot, that is what I will be focusing on my mind on, that how bad is the pain and which part of ambulation is most difficult. Is it the first few steps which are difficult, or the patient cannot stand at all, right? So those aspects will be very important. The another part which we got from the little piece of data which we have so far is that patient had calf pain for 2 days, which then went away. So we need to see that what happened 1 week ago, that there was calf pain, and how bad was that pain, right? Was there some kind of muscular pathology which was going on there, and then subsequently it went away, but now it is presenting in some other form. Maybe the pathology was in muscles, then subsequently it went to nerves, maybe spinal cord, right? So we need to characterize that problem better. And one might ask that why just calf muscles, right? That why only those regions of the body was involved, why not something else? So that will be important. And then finally, the patient had numbness in the right toe. So we know that things evolve in medicine, right? That as of now, the patient had numbness in the right toe only. What if tomorrow the numbness spreads to the entirety of the right extremity, and maybe 5 days later it spreads to the left extremity as well? So sometimes when the disease is evolving, you may not have a clear picture of what's going on. So you take it easy, take it one day at a time, and then see what is the complete picture in front of you, and then you try to make the analysis. So in my mind, I'm still trying to figure out that what happened with the muscles, what happened with this numbness in the toe, And as we get more data, we'll be able to piece it together. What do you think, Dr. Singh?
I think you articulated that very well, no pun intended, but going through an approach that is anatomical and also going through maybe focusing on the neurological aspect. When you don't move, are the nerves intact? Nerves run from brain down the brainstem to the end of the toes, right? So anything along that pathway could cause trouble with walking. What you could turn to in trying to decipher what's causing this issue. You could go system based, you can go anatomical based, you could go maybe pathological based. So if we use the pathological approach, is this something that is inflammatory? Is this something that's infectious? Is this something that's trauma? We kind of do need some background. This happened over a week's time, so it's something triggered this. This is not something that's relapsing, remitting, coming or bothering the patient for some period of time. It's a young patient as well. Immediately when Sneha had mentioned 18-year-old, I'm starting to think, what do people at 18 years of age manifest with? Usually, maybe genetic issues, maybe something that's in the background, bad genes, maybe bad behaviors, or their substances, toxins, and so on. Then 18-year-old, say a boy is active, so trauma, you start thinking about it. Was there any kind of activity surrounding this episode? So trauma could be a calf muscle tear, something that's anatomical and cause a hematoma and compression on the nerve and cause something like compartment syndrome. And that could cause some issue like this as well. And could there be a autoimmune phenomena or something like this, infectious and so on? So like bad genes, bad behavior, bad luck as well. So that's where the trauma may come in. So my mind's kind of dwelling in these areas. But what will really move the needle forward is more information. What is accompanying this? So more review systems and more information as well about the background and past history and so on. We'll send the mic back to Sneha. Any other thoughts, Ketan, before we keep moving on? Okay, Sneha, all yours.
Okay, great discussion. So proceeding with the case, he came with an MRI spine which had been advised by a doctor he had consulted outside. This MRI spine showed mild diffuse disc bulges at the level of L3, L4 and L5, S1 levels. Apart from this, he could recall having some mild cold 2 days before his symptoms started. Going to the review of systems, he had no visual disturbance, no difficulty chewing, no difficulty speaking, no breathing difficulty, no bladder or bowel symptoms. He had no fever, no back pain or neck pain. So I'll stop here.
So this piece of information is interesting. We had gone through the an anatomical approach, and at any of the neurologic anatomy, any impingement or impediment in the transmission of the neuronal impulse, there can be dysfunction. So we have an MRI here, and this MRI is like showing major anatomical dysfunction. When you have a disc bulge, you will have major downstream effects distal to the bulge there. So when you have a disc bulge like this, you start thinking about what are the worst case scenarios that you can have in this case. So cord compression. What Sneha has done is given us very vital piece of information that there's no significant effects on like bowel, bladder incontinence. This would be an emergency. And I think we pretty much have the diagnosis. I need to get this patient to a neurosurgeon. But in this case, there are none of those findings, but is it still a case that's progressing to that complex? It can be, because you don't just suddenly have cord compression and that's it. It can actually move. This is a dynamic presentation. This can suddenly get worse. You can bring a patient in on Friday morning, and by Monday morning, they may not move their legs. They may not be able to have a bowel bladder continence, and you have complete cord compression there. So you have to be very you have to be anticipating the worst in this case. The second thing is we're also looking, wait, are there any other neurological manifestations? No, nothing upstream, no visual issues, no issues with muscles of mastication and chewing and so on, speaking. So nothing proximal, but distal. There's a lot of pathology there, especially with walking, and then the pain. So we have both. We have sensory impediment, and we also have we have motor dysfunction on both sides as well, because we have sent the toe numbness on one side, and also we have pain. Initially, well, it was pain, but now we have difficulty with mobilization. Uh, what do you think about this? This is interesting imaging. Somebody's bringing it with them. And is this a red herring? This may actually send us on another completely different path. What do you think, Ethan?
No, I agree with Dr. Singh that we have a piece of data, but we have to understand that how much weight and gravity we need to give to that symptom, right? Like this patient has some disc bulge. Now, spine disease is one of the most fascinating parts in the medicine. Like if you are a seasoned attending and if you are seeing patients in the outpatient clinic or in the ED, you will realize that about 20 to 30% of the patients who come to the hospital present with the back pain. And most of the time, we use the word like non-specific back pain, musculoskeletal pain. And the reason why the back pain is such an enigma in medicine is because even if you find something, let's say you find moderate to severe spinal canal stenosis, and let's say if you undergo the neurosurgical procedure, will it mean that after the procedure your pain will go away? No one knows. Like I see so many patients who underwent the neurosurgical procedure, but even after that, they are still on like so many pain medications. They keep on coming to the pain clinic because their pain never went away. So that is the part about spine disease, which is always kind of fascinating that how much it is contributing to your disease state, either the sensory symptoms or motor symptoms, and would reversing it reverse everything as well. Now, the part which Dr. Singh mentioned is unequivocally true that if you have emergency, like your spinal cord is at the verge of collapse, complete dysfunction, then in that case, there is definitive evidence that if you reverse it, you will reverse the spinal cord compression and you will prevent the permanent paralysis or bowel bladder dysfunction. But it is the scenarios like one we are dealing right now, intermediate, that patient is not at the verge of collapse. So far, we haven't heard from Sneha that, oh, patient is completely paralyzed, power is 0 out of 5, there is no sensation in the perineal area, bowel bladder incontinence. Then in that scenario, you forget about the diagnosis, you just call neurosurgery, remove the compression, and then try to employ the algorithm. But in such scenarios, I always take a step back and ask myself that, sure, there is a diffuse disc bulge. Is it bad enough to compromise the motor function? Because in general, disc bulge tends to cause sensory symptoms more and probably first than the motor symptoms. So people will complain of like radicular pain, maybe severe discomfort, which we haven't heard so far. Patient just had some calf pain, which could be related to the nerve compression in the right setting. Maybe it's the referred pain, but we still don't have enough data, right? And let's say that maybe this we do like another MRI spine with contrast and we find out there is a significant nerve impingement, like what Dr. Singh was saying initially. The question becomes that why would a young person have such kind of pathology, right? If this was a 70-year-old person with nerve impingement, sure, degenerative spine disease. But why a 18-year-old boy will get such spine disease? And then we will have to entertain other pathologies that are there any genetic disorders which can affect your spinal ligaments? Are there any metabolic disorders or like mineralization disorders, like let's say calcium or phosphorus, which are affecting the ligaments in some way? Or maybe there is some underlying phosphorus related process which is affecting the bones of your spine, and maybe that is causing the compression, right? So that pathway we should follow once we have more proof for that. Since we don't have proof for that, we should still keep our antenna off for every other pathology, right? Now, I will just briefly mention about these flu-like symptoms. About 10% of cases which you will read in any medical journals, any like GI, pulmonology, neurology, sometimes they will say that, oh, patient presented 2 weeks ago with like a cough or presented with like cold. And then immediately you will start thinking that, okay, what are the associations between the flu-like symptoms followed by diarrhea, flu-like symptoms followed by weakness, flu-like symptoms followed by confusion. So we always have this Venn diagram of flu-like symptoms with every organ system, because that is how sometimes infections can trigger so many downstream adverse consequences into the body. But also you realize that sometimes it's unrelated. So we are not sure if this flu-like symptoms was related or not, but if it was indeed related, then what are the hypotheses we should entertain? That how can the flu-like symptom from any viral or bacterial infection can end up triggering neurologic process? So actually it can affect every part of your CNS. So for example, flu-like symptoms followed by altered mental status, visual changes, could represent acute disseminated encephalomyelitis or ADEM, right? Flu-like symptoms followed by paralysis of the lower extremity can suggest transverse myelitis. Flu-like symptoms followed by ascending weakness could suggest Guillain-Barré syndrome, right? Flu-like symptoms followed by severe pain in the muscles could represent influenza causing rhabdomyolysis, for example, right? So we know that flu-like symptoms can affect every part of your axis. It's our duty to figure out that how much relevant is one part over another and how much investigations you want to do, right? Like, would you get respiratory viral panel? Would you get blood cultures? Would you get stool cultures? It is reasonable to obtain it if we don't find any other obvious evidence. So that is how I will keep that piece of data at back of my mind, that it may be unrelated, but if it is related, how it is related and how would we investigate for that? What do you think, Dr. Singh? Any poll that you have for these flu-like symptoms?
Oh no, I just love the how you brought in now flu into this, and it's happening. It's kind of quick before the symptoms started. If we just go through the anatomical abnormalities on this MRI, that L4, L5 can cause calf pain, can cause numbness. Usually the anterior portion of the foot is affected, so the toe is affected there. So L3, L4 would be like your quadriceps and so on. And so the MRI, I think, does explain the findings, but the flu or a viral illness won't show or won't result in like this amount of pathology in the back. It was interesting when you were talking about any congenital disease, autoimmune disease. I mean, spondyloarthropathies comes to mind. Usually you get a lot of enthesitis and other extraaxial manifestations as well. But there's no prodrome building up to this. So this is a first manifestations. You don't usually just have this amount of disc pathology. The only other thing I can think about, 18-year-old, maybe trauma from sports. Say this person was playing rugby or American football, you can sustain this amount of trauma, but there's nothing in the social history or the build up to this that there was any trauma. So it's kind of interesting. Maybe the flu, maybe that is a red herring. There could be a little bit of pathology there that the person has already pre-existing. Now the flu comes in and then creates a totally new cascade of events with this molecular mimicry. You have the flu virus and then antibodies reacting to the antigens and then turning around and attacking the nervous system as well. So you may have inflammatory, what do you call it, an AIDP or something like that, disseminated polyneuropathy. But let's see what Sneha has for us in the next aliquot.
Very exciting discussion. So I'll proceed with the case. So looking at the past medical history, he had a hypothyroidism for the last 2 years. He was on thyroxine, 25 mcg for it. No other medications, no alternative medicines, no over-the-counter medications. Going into the family history was no way contributory except for a consanguineous marriage in his parents. So going to the social history, again, it was non-contributory. He had no health-related behaviors. He didn't drink. He doesn't smoke. He does a drug use. Nothing significant. So after this, I will go on to the examination part. So the vitals, he was afebrile, temperature was 97, heart rate 83, BP of 130/70. His BMI was around 29. The general examination, he was not in any distress. He appeared little overweight. So that was about the general examination. Nothing else remarkable there. So going over to the neurological examination, he had a weakness of both lower limbs, which was more pronounced distally when compared to proximal parts. The weakness was bilateral in the lower limbs with a power of 4/5 at the knee, 3/5 at the ankle, and 1/5 at the toes. Upper limb power was normal. Reflexes were absent in both lower limbs, preserved in the upper limbs. Sensation, all modalities of sensation were preserved. He had no disturbance of higher mental function. There was no cranial nerve involvement. cerebellar signs were negative on examination. Examination of the cardiovascular and respiratory examinations were normal. So I'll stop here and we can have a discussion.
Yeah, for giving us data in a very measured way and only the things which we need, no red herrings. So I appreciate that. So to summarize the case, we are dealing with a young boy who is presenting with 1 week of symptoms. So flu-like prodrome followed by pain in the calves, some numbness in the toe. But then as we were discussing that things evolve in the medicine, right? So the current data which we have, if we had to summarize, we would say that it's a distal predominant isolated motor weakness along with areflexia and nothing else, right? So firstly, what do you make of the fact that there is nothing in the upper extremities but only in the lower extremities? So as again, that things can evolve, right? If something is ascending in your body, it is possible that maybe it hasn't ascended yet to the upper extremities and it will ascend unless you intervene maybe in like 2 or 3 days, right? So could this still be a disseminated process affecting the peripheral nervous system without any particular predilection for lower extremities? It is possible. Secondly, if we assume that, let's say this process is indeed going to be remain isolated to the lower extremities, then you start wondering that are we dealing with a pathology which is affecting maybe the lumbosacral part of the spinal cord or maybe the lumbosacral plexus itself and not the brachial plexus? And maybe that is why the process is limited to the lower extremity, right? So that is one caveat we have to understand. Second caveat, that what about the fact that reflexes are absent? What can you make of that? Now, from what we know, the disease has been progressing at least for 10 days to 14 days now, because it started 1 week ago, and by the time the patient came to this center, it has been like few days, right? So if you entertain the fact that what if this person still has spinal cord issue, and the reason why you are not seeing hyperreflexia is because patient is in so-called spinal shock state. It is reasonable to assume that. And some people believe that the spinal shock state, as in like you don't have the expected hyperreflexia, can persist for few days to few weeks. And atypical presentations always happens, right? So can we say with absolute certainty that the absence of reflexes rule out the spinal cord pathology? Probably hard to say. Of course, it's lower on differential compared to the peripheral nerve process, given the fact that the sensory modality is completely intact. Because what happens is if your spinal cord is impacted, it's very hard to impact only limited parts of the spinal cord. Of course, there are syndromes like anterior cord syndrome, posterior cord syndrome, by which you can get isolated motor or sensory deficits. But in general, spinal cord processes tends to be non-specific and disseminated. So I would expect that if this was a myelopathy problem, then maybe there was some degree of barbitral dysfunction, maybe some degree of dysesthesia, paresthesia, none of which I'm seeing. So my suspicion for isolated spinal cord process would be lower on the differential, right? So now coming to the fact that you have areflexia, could it be in the peripheral nervous system? Could it be a muscle problem? Now, in general, if you have severe myopathy associated with atrophy of the muscles, then you might get hyporeflexia. But getting areflexia in such a short span of time from a muscle pathology is unlikely. What about the neuromuscular junction pathology? So neuromuscular junction pathologies, there are so many subtypes of it, and there are certain unique subtypes which may present with areflexia. So the neuromuscular junction possibility is still on the radar and we cannot rule it out. But given the fact that we are not hearing the bulbar symptoms, it makes it again lower on the differential, because the classic neuromuscular junction disorders, for example, let's say myasthenia gravis, let's say botulism, usually present with the bulbar symptoms. The Lambert-Eaton is an exception, which may not present with the bulbar symptom. It may start in the periphery, but it would be unusual that it would present at such a young age, especially in the absence of any known malignancy, right? So having ruled that out, our focus goes to the peripheral nervous system and primarily the motor system, the motor neurons which are coming. And that fits the picture very well, that you have a flu-like symptom, you are presenting with the distal weakness, more common than the proximal weakness, and you have areflexia. The reason why the distal weakness makes sense, because in general, the myopathies and even the neuromuscular junction disorder, which we talk about, present with the proximal weakness. The fact that you have distal weakness makes you wonder that is it a pathology which is affecting your nerves? And we know that usually the distal part of the nerves are most likely to be impacted first in common group of pathologies, and then that pathology moves proximal and you have the proximal weakness as well. So having said that, you start wondering that what kind of process can impact a young person following a flu-like symptoms, right? So as we were discussing in the first aliquot, that there is something known as like Guillain-Barré syndrome, right? Which is like a common colloquial term, but there are so many subtypes of GBS. And one of the one which Dr. Singh mentioned is like AIDP, which stands for acute inflammatory demyelinating polyradicular neuropathy. So the P part is very important, that it is not just polyneuropathy, it is polyradicular neuropathy. So it affects the nerve roots as well, not just peripheral nerves. And GBS, depending on which subtype it is, there are unique antibodies associated with GBS. And usually those are the ganglioside antibodies. And we know that your peripheral nervous system has the ganglioside antigen either in the axon or in the myelin sheet surrounding it. And because of the molecular mimicry, sometimes following an infection, you can form antibodies which can hit these antigens and can damage your nerves. And the classic pattern is the ascending pattern with areflexia. So that fits well with this picture. And what are the other ways in which you can confirm it? So I guess since it's already 1 week into the illness, if we do the EMG NCS on this person, that would be very helpful, because EMG NCS can guide us perfectly that where is the problem in the neurological axis. Is it at the level of nerve root, like the anterior horn cell, or is it at the level of peripheral nerves, or is it at the level of muscles? And EMG NCS is also helpful because sometimes people can have two process, right? So that, like for example, people can have myeloneuropathy, people can have myoneuropathy. So muscles and nerves, nerves and spinal cord. So like any combination is possible. And sometimes examination may not help you that much. So EMG NCS will be absolutely crucial, right? And then another very important test is that lumbar puncture, right? That ideally in the peripheral immune-mediated neuropathies, we expect what we call as the cytoalbuminologic dissociation, meaning that if you do the LP in the CSF, you will find that the protein levels are elevated, but the WBC counts are not elevated. They are usually normal. And in fact, this pattern is like so important that if you see the WBC count being elevated as well, then suddenly you start thinking that, maybe the process is more sinister than what I imagined. Maybe it is not just peripheral now. Maybe this person has transverse myelitis. Maybe it is something more in the CNS, not in the PNS. So that is how I'm going to analyze this problem, that I'm not going to anchor completely that it is in peripheral now. Maybe it could be in spinal cord as well. But the preponderance of evidence which we have suggests that it's a peripheral nerve pathology. What do you think, Dr. Singh?
Absolutely. I think you nicely have laid out all possible causes. With this case, it's very interesting. You follow the narrative with the two main agents, or what do you call it, the competing bits of information that are adding to this narrative, or what you called overlap. You got the spine, you got the viral illness, and I think here what's fitting the pattern, if you just take the spine, or we call radiculopathy, it's usually a very gradual sort of presentation, which doesn't fit. This happened immediately right after, within that 1 week to 3 week period that you get after a viral illness. And usually with this radiculopathy that you may get, it's usually the disc pinches on one side. So it's usually one-sided, but this is happening on both sides, which fits both nerves from the root down are being affected. So it's 1 point more for this post-infectious neuropathy that we're getting versus maybe this disc bulging as well. Could it be disc bulge with the viral radiculopathy on top of that? Could be as well. But he's never had any symptoms before this. So I would say, again, it's interesting how much weight did you had mentioned, how much weight do we put on the MRI? It explains everything, but again, it's not totally everything if you think about it. So, could it have lowered the threshold for something like this? Not really. He had no symptoms before this. So I think he came into this picture with that, but what's happening, he's being hit from the other side or blindsided by this post-infectious component. And I think we do have to look in the spine and GBS. Suddenly, you do get most of the manifestations distal and then proximal. 10%, we did have a case once where a patient actually had it in the arms. 10% of cases can present with manifestations just in the arms and not the legs. So you always have to be careful. So there was a case presented, and it stumped a lot of us many years ago. I think who was Aaron Berkowitz was maybe facilitating that case. So you always do look out for that. There's also these other kind of associations that you may get sometimes. Autonomic dysfunction is another one. So not everybody will manifest with that. And then also this albumocytologic dissociation, which is interesting. We've had this many times on VMR as well. And you don't always, I forget the percentage, but it's not always present. But if it's present, it definitely will be the piece of evidence that will help us to nail the diagnosis. But I definitely think you do have to look at that because this fits that picture very well versus just the MRI itself. Any other
And
thoughts before we go back to
yeah,
Sneha?
perfect, Dr. Singh. In fact, like while I was listening to you, I was getting the thought that as you said that we are going to take the flu-like symptoms in context, right? That it may be related, maybe unrelated. And like oftentimes, as we know that what happens is when our body is under some kind of stress, other underlying pathologies might come to the forefront. So for example, like the first thing you mentioned in the prior aliquot was like young person, could it be bad genetics, right? So the question becomes, is it possible that this person has some genetic disorder which might be impacting the spinal cord, peripheral nerves, muscles, and maybe this metabolic stress which patient had in form of infection, maybe now it is present. And we know this for a fact, right? That there are so many genetic disorders which do not present on day one when you are born. It presents at different times of your life depending on what kind of disease it is, right? So I will also keep that at back of my mind. And even more so because like the family history mentioned that there is some like consanguineous marriage. Now again, like there are so many people who might have consanguineous marriage and they will be fine, like they won't have genetic diseases. So again, not anchoring to that, but we will take every piece of data in context, right? That if it fits the GBS pattern, it looks like immune mediated, fair enough. But if it does not, then you start wondering that could it be genetic neuropathy, some of which can present in the distal length dependent pattern, especially at this age, like teenagers, right? So excited to see, Sneha, what next piece of data we have.
So next we look at some labs and imaging. So the basic workup revealed the hematology with a total count of 7,900, hemoglobin of 16.6, platelet of 3.61. The chemistry revealed the creatinine of 0.58, BUN of 9, and the sodium of 135, and the potassium of 4.3. So all of these units, basically these lab parameters are normal, within the normal range. An albumin adjusted calcium of 9.2, which is normal again. So he had a thyroid profile revealed a free T4 of 1.39 and TSH of 8.19. B12, vitamin B12 level was done, and the B12 level was 523 and within the reference range. Random blood sugar was done and it was 197. This is in milligrams per deciliter, slightly above the normal range. We proceeded with a lumbar puncture, and the CSF analysis revealed a cell count of 10 cells, with one being neutrophil and the rest being lymphocyte. The CSF biochemical analysis revealed a glucose of 173, protein of 149, and the chloride of 129. We did an MRI brain as well, and it was completely normal. We did a nerve conduction study, and the nerve conduction study of the lower limbs revealed bilateral lower limb CMAP could not be obtained, and SNAPs also could not be obtained. The nerve conduction study of the upper limbs, both side median and ulnar nerves had a conduction velocity which were normal, but distal latency and F-wave latencies were prolonged. The left ulnar nerve CMAP was reduced. So I will stop here. And,
Well, thank you, Sneha. I may have to lean on you just to repeat some of the information as it comes. So I think the labs are very interesting here because we do think it's an anatomical issue, but you can't help but always think about the what is the milieu within which the nerves they function, right? So the milieu is the electrolytes, right? So nerve function is sort of analogous to a car battery. Impulses are electrical impulses, and salts are common in batteries to generate impulses to drive your electronic mechanical um, devices. So here, the nerves need energy, they need a certain electrolyte balance, they need also endocrinological balance, you could say as well. And here, so the labs are normal, so we can at least exclude this. And what's interesting, you mentioned certain other some vitamins, B12 is normal. Although you do want to do a methylmalonic acid, sometimes you can have a normal B12. But the pattern of B12 deficiency with a subacute combined degeneration doesn't fit this picture. So less likely that, and I would kind of move away from that. The other thing is the thyroid you mentioned initially. I didn't really dwell much on that hypothyroidism, but usually you would have this is more of a distal issue than a proximal, but you would have proximal weakness or proximal limb weakness, which is not the case here as well. So I think that what really does help would be the CSF analysis. So we see 10 cells. I don't know what there's one neutrophil, 9 lymphocytes. So to me, it's like not too exciting there. And how much was the protein again? Was
The
oh,
protein
protein's
was
down there. Okay, I see it at the bottom. Okay. So glucose high, protein. I think is that high for the normal value? I don't remember the
yeah,
numbers.
it's quite high. Yeah, the normal value would be
Okay.
to be less than 45. It is 149, the protein.
Okay, so the certain things or certain pattern recognition you would have with the CSF, when you see a lot of protein, there's extra material that's floating within the CNS. What is that extra material? It could be cells from infection. It could be cells that are immunoglobulins that are acting upon the CNS system. So it could be a various number of different things. It could be prions in Creutzfeldt-Jakob disease. So these proteins could explain that there is something that's foreign to the CSF that is exerting all of this pathology here. And then I'll allow Kirtan to dwell on the nerve conduction studies. I remotely remember what F waves were, but if you remember, you can elaborate on this.
No, perfect, Dr. Singh. I agree with your analysis that first we need to think about pathologies outside the CNS. It is very similar to how we deal with AMS, that when someone has AMS, the most common things which we know is going to be exogenous influence on the CNS, right? We think about drugs, we think about electrolytes. I think same is true for peripheral nerves as well, that you always want to rule out the low-hanging fruits, that what if this person's potassium was like 1? And then we thought that, oh, this was periodic paralysis, right? What if this person was just exposed to a chemotherapeutic agent, which is known to cause neuropathy? Then again, your analysis will be completely different, right? So I think the way you kind of primed us that, hey, I don't see anything which is dramatic, like sure, TSH is a little bit high, but again, like the acuity of presentation doesn't make sense. Similarly, sugar levels are a little bit high, and diabetes can cause tons of neuropathies, but we haven't heard something was present 1 week before. Why now, right? So all those things kind of make us wonder that probably the pathology is in the CNS itself and not probably from the exogenous influence, right? Now, having said that, there are certain disorders which we have to entertain whenever we say GBS and GBS like differentials. And I'm going to like share that schema in the chat as well, that whenever you see a young person, or for that reason, any person who is presenting with acute onset of weakness, and you think that it might be GBS because it's like one of the very common prototypical disorder, you always have to go through the GBS mimics and its differentials. And the differentials are basically trying to tell you that where is the process localized? Is it at the level of spine? So as we said, the transverse myelitis and things like that, which we already ruled out. We did the MRI of the brain and spine. We couldn't find any conclusive evidence of any pathology there. So that becomes less likely. Then you think about the peripheral metabolic issues, which Dr. Singh highlighted, like some thyrotoxic periodic paralysis, electrolyte issues, any toxins, like if this patient like went to like I don't know, surfing or swimming and then was bitten by a fish, then you kind of worry that, oh, could it be paralytic shellfish poisoning, right? If this person was in US and was bitten by a tick, then you think that, oh, could this be tick-borne paralysis, right? Or if this person was in one of those endemic regions where you get like random viruses like West Nile virus, which can cause facet paralysis, right? So all those things are in the differentials of GBS. But the reason why all of those differentials go lower on our differential is because of the CSF profile. That almost none of these disorders will present with this pattern which we are saying, the cytoimmunologic dissociation, which usually points to the fact that there is intrathecal inflammation going on. Maybe that is why you have high protein, because the blood-brain barrier has been disrupted and there is no infection. That's why the WBC count is relatively normal, right? So if we take a moment and kind of ask ourselves that what are the differentials for cytoimmunologic dissociation apart from GBS or CIDP? So the differentials are kind of narrow. So if this person was older, let's say like 55 years old, then sometimes we know that in older people you get paraproteinemias like MGUS, myeloma, amyloidosis. And oftentimes what happens that those proteins can leak in your CSF and can cause such kind of dissociation. So oftentimes people who have paraproteinemic associated neuropathies, they might have some degree of dissociation. This person is too young, so the suspicion for paraproteinemia is lower on our differentials. So unless this patient doesn't respond to the classic therapy for GBS, one would not send the SPAP and immunofixation, right? Similarly, interestingly, diabetes actually is known to cause cytoimmunologic dissociation as well. And oftentimes we don't know about this much because if someone has diabetic neuropathy, we are not going to do CSF on them, right? But in undifferentiated cases, when people do get CSF, they often find out that diabetes is also one of the factors which can cause dissociation. Often these are the poorly controlled diabetic people. Our patient has slightly elevated sugar, but I don't suspect it to be the prime reason because the acuity of presentation. And of course, you can get A1C if nothing else is making sense. And then there are some unique genetic disorders. So the classic ones we talk about is the Refsum's disease, and another one is Charcot-Marie-Tooth disease. And Charcot-Marie-Tooth disease has so many variants, and similarly, Refsum's disease has some variants. And some of these variants are known to cause cytoimmunologic dissociation as well. But in these syndromes, often you see the extra neurologic manifestations, which we haven't seen, like maybe their cognitive function is slow, maybe they have delayed milestones, none of which we are seeing. So the reason why I laid down this differential is to highlight that although there are limited differentials, it's in a young person, it's often wise to go through all of them, kind of, checkbox approach so you don't miss anything. But having said all of this, now the GBS becomes most likely because we don't have any other evidence for anything else. And then the part which Dr. Singh was saying that what about this EMG no connection study? So again, like I'm not an expert, but from what I know is that the C map is like the compound muscle action potential or kind of like the amplitude. So often one like crude approach, which doesn't always stay true, but this is one crude approach that if you have axonal process going on, axonal neuropathy, then often your amplitude goes down, but your velocity of conduction remains unimpacted, at least earlier on in the disease process. And on the other way around, if you have demyelinating process, the amplitude of your action potential in the nerves stays intact, but the velocity takes the hit because myelin is very important for the velocity, right? And often these words, which when we see in the report that distal latency prolonged F wave, often it points that maybe there is some degree of demyelination because F wave latency has to do with the velocity of nerve conduction. So I start wondering that, well, can this person have a demyelinating process? And what is the official interpretation of these reports? What if it is actually demyelinating neuropathy? Then it would be a very good story for AIDP based on the clinical presentation, flu-like symptoms, areflexia, dissociation, everything will fit well, right? The only caveat which I will mention is that practical purposes, if you see such person, definitely as soon as they hit the your hospital, they will be started on IVIG once you rule out the infections, right? And this is very important because in GBS, some studies suggest that IVIG doesn't really like make any difference. The disease will itself take care of itself, and maybe the patient will improve on its own. But some studies do suggest that giving the IVIG earlier on can impact and accelerate your time to recovery. So maybe if you are going to recover, let's say at 4 weeks or 6 weeks margin, after getting IVIG, you will improve at the 2 weeks margin, right? So that's why giving IVIG is absolutely essential. And I think it makes sense since we have exhaustively ruled out the other pathologies and there are no absolute contraindications. Usually transverse myelitis is something which you want to rule out before giving IVIG, which I think we ruled out. and it should not present with this profile. It should actually present with high CSF WBCs, right? The only caveat which I would mention is that what other acute inflammatory immune-mediated demyelinating neuropathy can present like GBS but will not respond to IVIG or plasma exchange. So this is the rare disease which we actually talked about just today itself in like the prior neuro VMR, is what is known as autoimmune nodopathies and paranodopathies, that usually the GBS is directed towards the ganglioside, which is present in the axon or myelin sheath. But then at the nodes of Ranvier and at the paranodes, there are certain unique proteins. Like the classic example is the neurofacin. And these are the proteins which, if you form antibodies against them, these are different kind of antibodies which do not respond to IVIG, and they respond better to like rituximab. So you give IVIG, they will not respond. And only when you will give rituximab, they will respond. But these kind of diseases are extremely unusual. So it's not something you should consider upfront. This person should get IVIG and doesn't even need antibodies in general. But in case they do not respond to the classic expected trajectory of GBS, then you should send the extended ganglioside and nodopathy panel and try to consider any other therapeutic options that you might consider. What do you think, Dr. Singh? Any other differences that we are missing or maybe we should entertain?
Oh no, I think you're doing a marvelous job there trying to explore esoteric and maybe the more likely causes. So I think yeah, let's swing the mic back to Sneha. I think we're pretty much on the AIDP train for now.
So we also went in the same direction. We admitted this patient, started him on IVIG. He was given over a 5-day course according to his weight. He was on physiotherapy during this admission period. We did not find any remarkable difference during this period, and he was discharged home. He was following up with us for the next few weeks also. And in the meantime, he also was having diabetes, so he was started on an oral hypoglycemic agent. And we did antibodies to rule out latent LADA also, and these are negative as well. And he also was started on statins for dyslipidemia. So I'll stop here, and I have one more aliquot before I finish.
And Sneha, just to clarify, you said that patient got IVIG, and did he improve on the follow-up or he didn't improve?
He didn't.
He didn't improve. Okay. And I presume at this time, the MRI spine and everything, like even the repeat studies were okay, right? There was no concern of a CNS process.
No,
Right.
we had consulted even with the spine surgeon as well, and they felt that the disc bulge was not contributory to the patient's presentation. So,
I see. I see. And this EMG MCS report, what was the official interpretation by the neurology? That is it consistent with demyelinating versus axonal?
yeah, he had features of both demyelination and axonal damage as well on the MCS study. That was the final official diagnosis.
I see. And the last clarifying question I had was that when we saw this patient, like how farther we saw after the treatment, and any new symptoms or the same symptoms, that just motor weakness and nothing else?
So, this patient did not have any progression of symptoms. We followed him up for the next 1 or 2 months, and then we lost him. We lost him to follow up. And during these few months after the IVIG, he had no improvement in his symptoms, and he had significant disability. He required support for all his activities of daily living. He could barely stand for 5 seconds without difficulty, and he had to mobilize with a walker. So this was his status at the end of 2 months follow-up.
Thank you. Dr. Singh, maybe I can pass mic to you first. And what do you think?
Very interesting. I thought like you had mentioned, we tested our hypothesis with treatment, which would both test and also give us the diagnosis, or test plus treat the condition, but we didn't achieve the result we wanted to. What's interesting now, Sneha's introduced, remember you talked about diabetes and its effects. So this patient is now being treated for diabetes. But from what I remember, diabetes is usually sort of slow onset and reflexes don't usually go away this quick. This is exactly like an acute, like a insult right away from the get-go. The reflexes go, there's weakness, there's sensory impairment, and this is more along with the demyelinating polyneuropathy schema. Diabetes less likely, I would say, in this case. And you won't get this demyelinating pattern with diabetic associated nerve pathologies. So, yeah, at this point, I'm kind of interested to see, yeah, what do you think of this at this point? Um, Unless it's one of
Yeah.
those conditions where you had mentioned the subsets
Yeah.
of Guillain-Barré.
Yeah, Dr. Singh, I agree that it's a very tricky situation we are in, that usually IVIG, regardless of the subtypes of the classic GBS, do respond a little bit. And as I said, that even if IVIG didn't work, GBS itself tends to respond a little bit just with the time itself, that people improve a little bit of function. But this gentleman, like, if anything, maybe a little bit worse, that now cannot even do the activities of daily living, right? So whenever you see such scenario, non-responsive to treatment, the first thing again, you start with the square one, that, hey, did we miss anything else, right? So again, do a very good examination, see there are no other symptoms, maybe repeat EMG and CS to see if the process is still limited to the neurons itself and hasn't moved to muscles, hasn't moved to the spinal cord, maybe a repeat imaging of the spine, repeat reflexes, right? So you don't want to miss alternate pathologies. But let's say that Sneha's team did the appropriate stuff, they did the repeat examination, and everything is still consistent with the peripheral neuropathy, that there is areflexia, only motor symptoms, nothing pointing to the spinal cord. Then what is still remaining, right? So one possibility is that, as we discussed initially, that maybe it is not the classic GBS. And now, actually, we should not use the word GBS at all, because we have crossed the 4 weeks to like 6 weeks threshold. So this is more kind of like now CIDP kind of pattern. And we know that CIDP has so many subtypes to it, right? And the important one, which I also shared a link in the chat right now, is like the so-called nodopathies and paranodopathies. So the classic antibodies is like neurofacin 155, then there is contactin, then there is Caspar antibodies. And all these antibodies are notorious to cause such a profound degree of neuropathy that it doesn't respond to the classic therapies. And even after rituximab, they may not respond. So I think now we have crossed the threshold that we should send for these antibodies to see that maybe this is what is at play. And similarly, we should send the ganglioside antibodies as well, because the ganglioside antibodies will also take care of like the other subsets of antibodies like anti-GM1, anti-GD1, anti-MAG antibodies, which are again in the subtypes of CIDP and which can present in the weird, unusual forms. And what you need is maybe rituximab, right? So I will send those neuropathy antibodies. Let's say if we send all of that, we give rituximab, nothing works. Antibodies are negative, rituximab is not doing the trick. Then what should you do? So what I had mentioned, that in the differentials of cytoalbinologic dissociation, two unique congenital neuropathies fall. One of them is Charcot-Marie-Tooth and its subtypes, and another one is Repsom's disease, right? So I would send the genetic sequencing for the peripheral neuropathy. And because these two neuropathies are very common, can present at this age and can present with the dissociation as well. There are other forms of rarer peripheral neuropathies which can happen in young age, but almost all of them. So for example, there are subtypes of amyloidosis which comes in young age. There is like subtypes of leukodystrophies which comes in young age. But with normal spine, normal CNS, no other pathologies, it's hard to take a leap to those disorders. So the only two disorders which comes to mind, which is isolated neuropathy, is the Charcot-Marie-Tooth and Repsom's disease. So you might entertain sending the genetic sequencing for them as well. And in the nutritional realm, I would say we did check the B12 and stuff, but if the suspicion is high, checking for copper levels, vitamin E, vitamin B6, right, zinc, and even celiac antibodies, because like patient has this diabetes, which we are not sure where did it come from, then what is diabetes usually associated with in young people, right? It is associated with thyroid dysfunction, which this guy has, and then it's a celiac as well. And we know that celiac disease can come with like very strange autoimmune manifestations, including neuropathies, even outside of the nutritional disturbances, right? So that is how I will do. Send for those ganglioside antibodies, neuropathy antibodies, check for Charcot-Marie-Tooth and stuff, check for nutrition, check for celiac, and then see what happens. Dr. Singh, anything to add before we get the final review?
I just love the potential hypotheses that you mentioned, copper came to mind too. What if, again, is this something outside the system? But we don't have the hematological association, the anemia, neutropenia. So it's kind of odd. Although you never know. Next week they may have anemia, neutropenia in this case. You know, the issue with this, I was thinking, yeah, maybe Charcot-Marie-Tooth disease. That's a kind of a long, kind of winded presentation. You get the anatomical abnormalities, the inverted champagne glass, lower extremities, pes cavus, hammertoes, all those kind of abnormalities. It doesn't kind of fit. That's more like this chronic, although we're into those 4 weeks, but we don't have those anatomical abnormalities there. So something bothers me about this case, right? If you think about it, there's potential, a lot of potential conditions, especially congenital problems, right? But they don't fit the picture, unless you could say it's an atypical presentation. But yeah, I think we were thinking solely on the nerve itself. Not a bad idea to think about all these other things, like you had mentioned, celiac, and then also copper. I know there's been a VMR on copper recently. It's becoming more and more recognized, but I don't see the associated features. But let's say we send all these tests, like we do in real medicine, we send a battery of tests and just hope one of them turn up positive. Back to you, Sneha.
Extraordinary discussion. So this is the process through which we went through also, and so he didn't come for follow up for quite some time, and then he came back, and we found that he was in the same state that he was in when we saw him last. And so initial our considerations were the contribution for the diabetes and the thyroid disease contributing to that thing, and everything was under control until he had the same weakness. So then we went ahead and did the antibodies for CIDP, nodal and paranodal diseases. And the antibodies against neurofacin 155, BD1B, DQ1B, GM1 were negative. But the antibodies against neurofacin 140 and 186 were positive. So therefore, we decided that we deserved a trial with rituximab, and after 2 injections of IV, 1 gram IV rituximab, his power improved. Now he was able to walk a few steps without support, stand for longer periods, and even climb stairs to an extent. So this is a recent thing. So he's been on physiotherapy, and his progress is being charted as we see him in the visit.
Perfect. Sneha, what a case. This is the kind of journey which we always wanted, that you presented case at the appropriate ways, that you gave the standard treatment, didn't improve, then your team followed up. And I also shared the schema in the group right now that we have presented one of similar cases before, that neurofacin 155 mediated CIDP mimic. And the reason why IVIG doesn't work is very important to understand, that the antibodies which we are talking about against the neurofacin 140, 186, 155, contactin, Casper, all of those are of IgG4 subtype. Usually the antibodies which we see in the autoimmune world, like let's say the classic GBS, lupus, rheumatoid arthritis, you name it, are of IgG3 subtype. And usually those are the antibodies which respond to steroids, IVIG, plasma exchange. But the IgG4 subtype of antibodies do not respond to all of this because of their pathogenesis, that the IgG4 antibodies cause the damage to the neurons, not by the mechanism of complement fixation, which is what other antibodies do, that it fixes the complement and that's why you can target it. But IgG4 does the damage by disrupting the adhesion between the different molecules. And when you're talking about the adhesion, it is kind of like a bland, non-inflammatory subtype. So steroids should not work. The only thing which works is rituximab, is because you want to target the B cells and the plasma cells which are producing this pathogenic IgG4 antibodies. So you are going for the core cause of antibodies rather than the downstream damage. Steroids and IVIG is like more downstream effectors. But if you want to uproot the core pathophysiology, then you need to target the B cells and plasma cells. And that is where the rituximab shines. So some people say that in the resource limited settings, if you can't send for these autoantibodies, giving IVIG is fine. But if patient doesn't respond in 1 month, like Sneha's team did, then you have to trial them on rituximab, even if you can't send for antibodies, assuming that it has to be one of these IgG4 antibodies, right? And also the fact that there is neuroimmunologic dissociation, like the protein is high, is also consistent, that almost all the nodopathies, paranodopathies do have this dissociation as well. So I'm glad that while we were discussing the nerve connection pattern, we were entertaining that, okay, we will send for these fancy autoantibodies if the patient doesn't respond. So fortunately, that is what happened, that we were able to track it at the right time. The patient didn't respond, and now the patient is making good progress. So very linear story, very well presented. What do you think, Dr. Singh?
Oh yeah, amazing, amazing story. This is a space I do not usually venture into, but I definitely learned a lot, and I definitely will be reading quite a bit. There's just so much out there, medicine so humbling, and I really appreciate Sneha bringing this, spending extra time and working hard to put this case together. It's just beautifully and wonderfully presented. So please do come back and present more cases, and maybe take away our neurophobia.
Perfect. Thank you so much, Neha. Again, like one of the most fantastic debuts which we have had. Any final words before we pass the mic to Eugene?
So this case was an eye opener for me. This was during my initial period when I had started seeing OP clinic patients on my own, and this is my first case of nodopathy that I had seen, and the first time I got introduced to nodopathy, and then I read a lot about it and all that, and then um, yeah, so I guess few things that stood out when I was reading is that there are few features like sometimes an early onset tremor or an ataxia can be a pointer to an underlying neuropathy, and the axonal damage here early on in the disease, and the CMAP, which was very drastically reduced in the along with the demyelination. These could have been pointers to a neuropathy, in the first presentation when we saw the patient itself. So, and also one other thing I was taken aback is that a lot of these patients have the nephrotic syndrome as well because of the immune complex deposition in the kidneys also. So yeah, so this is my journey learning in taking care of this patient, and, along with
Thank you
our
so much.
neurologist.
Yes. Thank you so much, Neha, once again for bringing this case. Thank you to Dr. Singh for excellent partner in my discussion as always. Thank you to Simi for scribing. And maybe you can pass the mic to Eugene to take us home with the teaching part. See, Eugene, if uh, is he in a place to mute or not? In case Eugene is not able to join, maybe the connection is weak. I think the teaching points are like they stand for themselves in the our whiteboard. He has done an amazing job, and maybe like I could just summarize. So like our journey with Dr. Singh began with like that young person with ambulation problems. First, you need to define the problem, right? That why someone is not able to ambulate. You go through the past medical history, try to find the clues. You narrate and you kind of narrow down a differential based on the examination findings. And in this case, given the fact that patient had areflexia, patient had conclusive evidence of neuropathy on the EMG NCS, and we ruled out other metabolic pathologies, other central pathologies based on imaging. So then our focus shifted to what kind of neuropathy is present with this CNS inflammation in the form of dissociation, right? And the most common is GBS. We tried to treat for it, didn't work. Then you follow them, follow the clinical trajectory. Since they didn't work, we can send the extended antibodies. We found the antibodies and we know that the pathogenesis is a little bit different. So we give them the targeted treatment and then hoping that with the PTOT, they improve as well. And that is what Sneha shared in the end as well, that there are other subtle clues, like you can think about ataxia, you can think about the nephrotic syndrome. And usually these are associated with the individual antibodies, like NF155 has unique association. Contactin 1 is the one which is associated with the nephrotic syndrome. So every antibody has their own associations, but I think the big takeaway is that always follow the patients like Sneha's team did. If they don't respond to standard treatment, then think about something else and broaden your differential. So yeah, those were the teaching points. Thank you so much again, everyone, for joining, and see you next time.
Thank you. Thank you, Kirtan. Take care, everybody.
Thank
Bye.
you for the assistance.